Hello, and welcome to PDPM, Navigating Our Medicare Future, brought to you by Therapy Center, your rehabilitation partner. Our objectives today are to gain a better understanding of the October 1st changes that will impact Part A Medicare, to review the framework of the patient-driven payment model, also known as PDPM, to better understand the increased importance of the MDS and MDS protocols underneath PDPM, to learn how PDPM differs from PPS, to help us develop strategies to adapt so that we are successful under PDPM, and finally, to understand the importance of timely ICD10 coding and accurate ICD10 coding. So who is impacted by the PDPM change? It only is going to apply initially to Medicare Part A patients residing in skilled nursing facilities and swing bed non-critical access hospitals. At the current time, HMOs and private insurances are not following a PDPM methodology, although this could change in the future. So why does CMS feel that payment change is necessary? Currently, under PPS, therapy accounts for over 92% of all submitted Medicare Part A RUGs. They question the accuracy and the need for RU and RV RUG utilization. CMS fears, as does MedPAC, that RUG levels are in certain cases by certain providers being driven by financial considerations instead of the care physically needed by the patient. PPS also carries with it a high administrative paperwork burden. Think about how many 5, 14, 30, 60, 90-day assessments your facility performs on an annual basis, and this does not account for unscheduled PPS assessments. PDPM seeks to reduce the overall paperwork burden, allowing us to spend more time in front of our patients. So what do we know? PDPM will completely replace PPS effective October 1st, 2019. There will be no transition period. On September 30th, you will be PPS. October 1, all Part A patients inside the SNF setting will transition to PDPM. PDPM's design is to remove bias from determining the level of care and move that care determination to condition-based based on patient characteristics. No longer will therapy minutes drive care delivery. PDPM is budget neutral. It simply seeks to reallocate funds based on patient needs, based on the characteristics and comorbidities stated above. Knowing that PDPM is budget neutral, let's take a brief look at how CMS has changed the reimbursement methodology under PDPM. Compared to PPS, which had two components, a component for therapy, a component to nursing, which were then added together to yield the patient's RUG level and therefore their reimbursement, under PDPM, there are a total of 5 components. A component for PT, one for OT, one for ST, one for nursing, and a new category called non-therapy ancillary, or NTA, which is a series of comorbidities that CMS feels, when present and captured on your MDS, show a higher acuity for patients that can positively impact your reimbursement. Continuing our comparison between RUGs 4 PPS and PDPM, under RUGs 4, as mentioned in the previous slide, there are 2 case mix components, one for therapy, one for nursing, compared to 5 under PDPM. PPS RUGs 4 has 5 PPS assessments, a 5, 14, 30, 60, 90, plus any start of therapy, end of therapy, and change of therapy OMRAs that may occur during the patient's stay. Under PDPM, there are only 2 assessments. OMRAs are gone. You will have an initial and a discharge MDS, plus an optional IPA, which we will discuss a little later. Under RUGs 4, payment during a ARD window remains constant. It can change based on the ARD. Under PDPM, however, the initial MDS sets payment for the entire length of stay. PPS relied heavily on therapy minute thresholds in order to achieve RUGs. Under PDPM, therapy minutes will be based on clinical need and not tied or tiered to RUG rates. Under PPS, there were group and concurrent restrictions. CMS is seeking to change in the proposed rule the definition of group, which will yield opportunities under PDPM for group to come back into daily therapy in a functional way. Finally, RUGS 4 is index maximizing, which means your MDS software automatically looks, based on the information inputted into the MDS, for the best paying RUG. Under PDPM, the rate is determined by the addition of all 5 of the aforementioned case mix components. This next slide, courtesy of ANAC, gives a good visual representation of how the individual case mix components add together to equal the resident's total rate. One of the big ways PDPM differs from PPS is the fact that each of the individual case mix components stands alone as far as needing to justify and support the services, the skilled services that are being provided. This was not the case under PPS. Continuing our comparison, under PPS, all residents fell into one of 66 RUG levels. The number of combinations under PDPM to yield the final case mix group rate is far higher. PPS does not account for comorbidities, so an RUB is an RUB, same rate, same payment. Under PDPM, in the example shown, resident A has a much higher PT need than resident B, who requires a higher level of nursing based on their complexities. We will use the rates in this next slide to help us with some examples. These are 2019 federal unadjusted rates for both urban and rural settings. Using the rates on the previous slide, we will now go through each of the 5 case mix components and determine both urban and rural what are the best case mix group and what is the worst case mix group for each. Using the formula listed above, SLP base rate times SLP CMI, and we will do this for each of the 5 individual components, we see that the lowest SLP case mix is a category called SA. It has an index of 0.68, and using the figures from 2 slides ago, the urban SLP per diem is $22.15. So what we do here, in order to see how much we will make, is to take the $22.15, multiply that by the index of 0.68, yielding $15.06 per day. Follow the same procedure using the formulas for the other 4 case mix components. After following the process from the previous slide for all 5 case mix components under PDPM, you see that the lowest possible reimbursement urban rates is $356.43. Apply the same process using the highest RUG levels, and the result is $1,063.75. These are urban rates. On the rural side, the lowest possible reimbursement is $372.94, with a highest possible reimbursement of $1,087.01. So what are our takeaways from this exercise? First, ICD10 coding matters. Based on the 2019 federal per diem rates unadjusted, the difference between the highest and the lowest rural PDPM rate was $714.07 per day, or $707.32 per day in urban settings. Second, accuracy with section GG is critical. Third, attention to MDS items impacting reimbursement is critical. Fourth, communication. Communication between the interdisciplinary team is a must. Success equals teamwork. On slide 11, you may have noticed that certain case mix components had what was termed an adjustment factor. CMS is calling this a variable per diem adjustment, or VPD. It only impacts physical therapy, occupational therapy, and the non-therapy ancillary components. CMS studies determined that the cost in these areas did not remain constant throughout the patient's stay. Constant per diem rates did not accurately reflect changes in resource utilization. And the case mix adjustment per diem is multiplied against the per diem adjustment factor for each day of the patient's stay. Nursing and ST do not have adjustment factors. So how does the variable per diem adjustment work for OT, PT, and NTA? For physical therapy and occupational therapy, their components after day 20 will see a 2% reduction every 7 days. Please refer to the chart on the right to see the day count and the adjustment factor applied. For non-therapy ancillaries, however, days 1 to 3 will see a 300% or 3 times the established value increase. On days 4 and beyond, the patient will return to whatever their established NTA rate was. The CMS TEP studies determined that in spite of declines in PT and OT payments because of the variable per diem adjustment, this should not impact the level of care delivered. Typically, less care is delivered by physical and occupational therapy later in the patient's stay, thereby administrative costs also decrease, equaling a zero impact. CMS is on record stating that they will be monitoring for premature resident discharges based on VPD. The non-therapy ancillary amounts of a 300% increase for days 1 to 3 are to account for increased costs for items such as medicine and supplies. Days 4 through the end of the stay are paid at 100% of the established NTA rate. Taking what we've just learned about variable per diem adjustments, let's look at the impact of the adjustment to physical, occupational, and NTA. On days 4 to days 20, you will notice that on this patient, and this is a sample patient, major joint with diabetes and a cognitive impairment, the base rate is $528.82. Now, remember that the NTA has a 300% adjustment for days 1 to 3, so that rate increases. So the facility on days 1 to 3 will actually see a reimbursement of $678.68 per day. Now, moving forward, the OT and PT components after day 20 will see a 2% decline every 7 days. So on days 21 to 27, the $528.82 drops to $525.01, and then taking it out all the way to day 100, the lowest possible rate or impact of the adjustment takes the rate down to $483.16 per day. Under PDPM, there will be 10 PDPM clinical categories: major joint replacement or spinal surgery, acute neurologic, non-orthopedic surgery, non-surgical orthopedic, orthopedic surgical extremities not major joint, medical management, cancer, pulmonary, cardiovascular and coagulations, and acute infections. These 10 categories are condensed into 4 PT and OT clinical categories. The major joint replacement remains the same. Non-orthopedic surgery and acute neurologic are combined. Other orthopedic encompasses the non-surgical orthopedic and the orthopedic surgical extremities, and medical management captures the other 5 categories. Physical therapy and occupational therapy rely on 2 factors to determine their case mix component rates. The first is clinical category. Which of the 4 categories does the patient fall into based on their diagnoses? The second is section GG functional score. These 2 items will determine the OT and the PT components. A final factor that may impact the overall rate, however, is whether or not variable per diem adjustments are in effect based on the patient's day count. Section GG functional scoring for physical and occupational therapy can have a total score ranging from 0 to 24 and utilizes 10 items of the MDS section GG set for its determination. For self-care eating, the score is 0 to 4, as is oral hygiene and toileting hygiene. For mobility, sit to lying and lying to sitting, a score is 0 to 4, but it is averaged based on those 2 item sets, add together, divide by 2. do not round. The same system applies to mobility sit to stand, chair, bed to chair, and toilet transfer. It'll be an average of those 3 transfer items. And finally, mobility walking at 50 feet 2 turns and walking 150 feet is a 0 to 4 score with an average of the 2 items taken together. It is not until you have completed the entire 10 items of section GG and added the scores that you will finally round up or down accordingly. The following slide represents the 16 possible case mix classifier groupers for occupational and physical therapy. Please note that unlike PPS, where the use of section G is in play, being more dependent does not always equal increased reimbursement. Let's look at an example of how the OT and PT calculation may look. Our first step in determining payment for OT and PT is to determine the clinical category. For this example, the patient is a major joint replacement or spinal surgery. Our second step is to determine their functional GG score. Here, it is 8. This results in PT and OT having a case mix group of TB. Please note that PT and OT case mix indexes are different. It is 1.69 for PT, 1.63 for OT. Utilizing our 2019 federal unadjusted urban rates in this example, for physical therapy, it's $59.33. We take that figure, multiply it by 1.69, the PT case mix index, and the facility will be reimbursed $100.26 per day for physical therapy. The same calculation applies for OT, where you take the case mix for OT of 1.63, multiply that by the urban OT per diem of $55.23, and the OT reimbursement will be $90.02 per day. These rates would apply for days 1 through day 20 of the patient's stay, and if the patient stayed beyond day 20, the variable per diem adjustment would apply of 2% every 7 days. As is also the case with the other 3 case mix components under PDPM, ICD10 coding and its accuracy and timeliness is critical. Comparing the highest possible CMI to the lowest possible CMI, a facility could see a difference of $49.83 per day based on the 2019 federal unadjusted numbers. A difference of $32.59 per day for occupational therapy. Once the 2020 final rule is published, probably at the end of July or early August, these numbers will change. Moving to the speech therapy component of PDPM, the factors that influence the speech therapy case mix include the presence or absence of an acute neurological condition, the presence or absence of a speech-related comorbidity, the presence or absence of a cognitive impairment, and finally, the presence or absence of a mechanically altered and/or swallowing disorder. The following speech therapy-related comorbidities will positively impact the ST component under PDPM if present. Aphasia, CVA, TIA or stroke, hemiplegia or hemiparesis, traumatic brain injury, trach care while a resident of the SNF, vent or respirator while a resident, laryngeal cancer, apraxia, dysphagia, ALS, oral cancers, or any speech or language deficits. The patient's cognitive status will be assessed in the exact same way under PDPM as it is currently under PPS. This can be good news or it can be bad news. Ask yourself, does my facility do a good job accurately recording BIM scoring or CPS scoring? If the answer is yes, it's one less thing you have to worry about in the PDPM transition. If the answer is no, it is one area that it is highly recommended as it now affects reimbursement that you strengthen in preparation for October 1 changes. Pertaining to swallowing disorders, This is MDS section K0100. It has a 7-day look back. And what you are looking for here is loss of liquids or solids from mouth when eating or drinking, holding food in the mouth, cheeks, or residual food in the mouth after meals, coughing or choking during meals or when swallowing medications, and complaints or difficulty or pain with swallowing. If a patient presents with one or more of these items, it is critical that it gets into the charting so that it can be captured on the MDS. Unlike physical and occupational therapy, which had 16 case mix classifications, ST only has 12. Providing an ST example of the case mix calculation, the first thing we are looking for is to identify the presence of a neurologic condition, SLP-related comorbidities, and cognitive impairment. In this example, 2 are present. The second thing we are looking for is to identify the presence of a swallowing disorder and/or mechanically altered diet. In this example, both are present. Moving this through the 12 groupers, we find that the patient has a case mix index of 3.51 with a case mix group of SI. We then take the 2019 federal unadjusted urban rates from earlier at $22.15, multiply this by the case mix index of 3.51, and the facility will receive a reimbursement for speech therapy services of $77.74 per day. The following MDS sections can both be key to the speech therapy reimbursement calculation, but also in the input that speech therapy can have and information they can provide to the MDS coordinator at time of the initial MDS assessment. These include acute neurological diagnosis, section I-20B, SLP-related comorbidities, I-4300, I-4500, I-4900, I-5500, O0100E2, I-0100F2, I-8000. Swallowing disorders, K0100A through D, mechanically altered diets, K0510C2, and cognitive impairment through the BIMS or CPS score, as these help determine a PDPM calculation. Following in the same footsteps as we did with physical and occupational therapy, and noting the difference between the highest possible CMI and the lowest possible CMI, in speech therapy, we can see a difference as much as $77.75 per day based on the 2019 urban federal unadjusted rates. Again, these rates will change once the 2020 SNF final rule is published. The following considerations can help you maximize the ST component under PDPM. First, when is ST evaluating? Early evaluation is key. This helps ensure that all information is available for the initial MDS assessment. This is to be completed no later than day 8, although industry trends seem to be leaning towards completion by day 7. How are your diet changes communicated? In your facility, who is completing the MDS Section K? It is essential that you have a system in place to ensure that information is being communicated timely and effectively. Communication needs to be thorough, documented, and reviewed. What does your staffing mix look like? Is your ST staff in the facility full-time or part-time? Do steps need to be taken to ensure early intervention? And finally, how is nursing documenting? Swallowing problems are reported in Section K of the MDS on supportive documentation. Please make sure nurses know how to document and communicate any noted issues such as coughing at meals or with medications. The PDPM nursing component. Under PDPM, there are 25 classifications. They are condensed versions of what is currently under RUGs, but the clinical qualifications for each category remain the same. Based on Section GG, remember Section G will be eliminated under PDPM, and there is no variable rate adjustment for the entire length of stay. Under PDPM, inside of Section GG, Nursing will be responsible to report on 7 items. Their score can range from 0 to 16. This is in contrast to therapy, who reports on 10 items and whose score ranges from 0 to 24. Nursing will score on self-care eating, a score of 0 to 4, self-care toilet hygiene. They will average mobility from sit to lying, lying to sitting on side of bed. The two will be averaged, as will the mobility sit to stand, the chair bed to chair transfers, and toilet transfers. Do not round up or down on those 2 item sets until you calculate the final score. You round at that time. The nursing classification category will be the same as it is under PPS, with the exception that impaired cognition has been removed under PDPM. Once the category has been assigned and a function GG score has been established, a CMI will result that will determine the nursing component. So what are some of the nursing considerations we should be evaluating in preparation for PDPM? First, what is your capacity to handle more clinically complex patients? Under PDPM, there will be increased reimbursement to handle more sickly patients. Will you be ready? Are you able to handle the increased workload and care that will be involved with those patients? Are there clinical capabilities that need to be developed or strengthened inside your facility? Do people have the right training to be able to do their jobs effectively? Examine your policy and procedures, including your admissions process. Does anything inside your admission process need to be adapted, revised, changed? Do you have the right people and the right job assignments to maximize the strength of your assets? And how will change to PDPM affect your facility assessment process? The final reimbursement component to be addressed is NTA, or non-therapy ancillary. The NTA case mix component will be based on the presence of certain comorbidities or the use of certain extensive services. There are 50 NTA items, and each comorbidity is assigned a point value. These points are then added to reach a final NTA case mix index. The NTA is subject to variable rate adjustments on days 1 to 3. Your facility will receive a CMI at 300% for days 1 to 3, then on days 4 to 100. The following 2 slides are the 50 NTA categories that can be captured as comorbidities for PDPM payment. There is a source to each one of these items listed, a point value, and CMS has created this on their PDPM website for download. Many facilities are choosing to use this in their admissions process to determine category. Remember, all the points, if a patient has comorbidities, are added together to achieve an NTA score range and thereby an NTA case mix grouper. To illustrate an example of how the NTA case mix index would work, let's run with an example and assume that of the 50 NTA items, the patient had what was equivalent when added together to equal 4. This equaled an NTA case mix group of ND with a CMI of 1.34. Using the 2019 federal unadjusted urban rates, an NTA base rate is established at $78.05. This is multiplied by the 1.34 CMI score you received for category ND to equal a per diem rate of $104.59 per day. Remember that 104.59 will be multiplied by 3 for days 1 to 3 and then return to 104.59 for days 4 through the rest of the patient's stay. So what are some ways that we can improve our accuracy in reporting NTAs? The first would be through clinical meetings, which should include the entire interdisciplinary team. Communication is critical. Review the resident's needs and diagnoses prior to admission, review new orders daily, and discuss the resident's condition. Second would be to identify changes in condition, the need for IV meds, wound care, intermittent catheterizations, suctioning as examples. Significant changes in resident condition and/or care after the completion of the initial MDS may warrant the use of the optional IPA, but this criteria for use of IPA will be determined by your facility. As we touched on when we were discussing the PT and OT CMI calculations earlier in this presentation, all Part A skilled patients will be classified into one of 10 PDPM clinical categories. 1. Major joint replacement or spinal surgery, non-surgical orthopedic, orthopedic surgical extremities not major joint, acute infections, medical management, cancer, pulmonary, cardiovascular and coagulations, acute neurologic, or non-orthopedic surgeries. The ICD-10 code used in item set of the MDS I0020B will define the clinical category. The MDS item I0020B represents the reason for the Part A stay, also known as the primary diagnosis. Mapping of clinical categories through ICD-10 can be found at the following website. Sections J2100 through J5000 are used to report surgical procedures that occurred during the patient's hospital stay. Items reported in this section are used with the patient's diagnosis information to classify the clinical category. Something new to PDPM will be the presence of return to provider codes, or RTPs. These are medical diagnoses determined by CMS to not be appropriate for use as a primary diagnosis on a SNF Part A stay. CMS will not accept any of these diagnoses if listed in I0020B. Return to provider codes may still be used if reported as secondary diagnosis, however, on the MDS. Although not an all-inclusive list, some examples of return to provider codes include essential primary hypertension, generalized muscle weakness, age-related osteoporosis without current pathological fracture, fractures to unspecified areas, dyspnea unspecified, shortness of breath, nausea, vomiting, and acute duodenal ulcer with hemorrhage. Your EMR should help you identify these and provide you with triggers to let you know that these will not be able to be used in I0020B. Coding for success under PDPM. The reason for admission always governs the selection of the principal diagnosis. The principal diagnosis is that condition established after the study to be chiefly responsible for occasioning the admission of the patient to the hospital for care. This definition applies to all non-outpatient settings, including skilled nursing facilities. When two or more interrelated conditions, each potentially meeting the definition of a principal diagnosis, either can be cited first, unless circumstances of admission, therapy provided, or tabular or alphabetic indicate otherwise. Refer to your ICD-10 manual for guidance. For residents who continue to stay in facility long-term, the condition requiring them to stay should be sequenced first as the principal diagnosis. An example of this would be a current long-term care patient goes to the hospital for acute pneumonia treatment and returns to the facility for further care of chronic COPD. That is the condition that was requiring the long-term care stay, while continuing to receive antibiotics for the acute pneumonia. In this instance, COPD would be listed as the principal diagnosis and pneumonia would be an additional diagnosis. As referenced at the beginning of this presentation, currently under PPS, over 92% of all Medicare Part A RUGs are assigned as therapy RUGs. When the reason for admission is for rehabilitation, sequence the first code for condition for which the service is being performed. For example, patient is admitted for therapy for right side dominant hemiplegia following a CVA. Code I69.351, hemiplegia and hemiparesis following cerebral infarction affecting right dominant side. If the condition for which the patient is receiving rehab is no longer present, report the appropriate aftercare code as the principal diagnosis. In this example, the patient is admitted for therapy following a right hip replacement for treatment of severe degenerative osteoarthritis of the hip. Here you would code Z47.1, aftercare following joint replacement surgery, as the principal diagnosis, and Z96.641. The therapy primary diagnosis may differ from the principal admission diagnosis. The primary diagnosis is the reason for therapy services. The primary or medical diagnosis code on the therapy evaluation and plan of care must support the therapy services as documented by the physician. This may not necessarily be the same as the reason for continued stay in the facility, which is the principal diagnosis. For example, a resident with Parkinson's disease returns after a Medicare qualifying stay for pneumonia to start a new Medicare Part A stay. Pneumonia is listed as the medical diagnosis on the therapy evaluation and plan of care to support the therapy services along with the appropriate therapy treatment diagnoses. However, Parkinson's is the reason for the continued facility stay, which would be the principal diagnosis recorded in I0020B, and continues to be sequenced first on the diagnosis list and the UB04, with pneumonia being second. For those familiar with the UB04 for billing, the principal diagnosis will be recorded in FL67. It is required on the UB04. The condition chiefly responsible for the patient's admission or continued stay and should match item set I0020B. When coding other diagnoses on the UB04, include these diagnoses in columns 67A to 67H. You may not duplicate the principal diagnosis listed in FL67 as an additional or secondary diagnosis. Medicare will ignore data listed in 67I through Q. Those are available, however, to include on your UB04. It only uses data and codes listed in 67A through H, those 8 codes. Codes listed need to support the need for the SNF stay and reflect the patient's clinical status. Let's take a look at a UB04 coding example. Here we have a resident admitted for OT-PTSD following a CVA with noted right side hemiparesis. The resident also presents with Alzheimer's disease, dementia, and type 2 diabetes. On the MDS in section I0020, the primary diagnosis we'd code as 01 stroke. In I0020B, we will record the CVA, I69.351, followed by I2900 diabetes, I4200 Alzheimer's disease, I4500 CVA, TIA stroke, and I4900 hemiplegia or hemiparesis. On the UB04, under FL67, we will add the CVA with right-sided hemiplegia, I69.351. In box 67A, we will use G30.9 Alzheimer's, 67B, F02.80 dementia, and 67C, E11.9 type 2 diabetes without complications. All members of the interdisciplinary team should understand the relationship between coding and billing. Accurate and complete ICD10 codes and HCPCS codes are necessary in order to bill. We must understand how coding links to the billing cycle. ICD10 codes on claims provide information on the medical necessity of the services that we are billing. We're looking to paint a picture of the patient's condition. Each code must be supported by physician documentation. Inaccurate codes could be considered fraudulent billing and subject to medical review and payback. Ensure a process is in place to validate diagnosis codes with the medical record documentation, the MDS, and the UB04 prior to claim submission. Let's look at a couple coding examples. For our first patient, scenario 1, the patient is admitted from hospital following AAA repair with graft. During hospitalization, the patient was also noted to have chronic kidney disease stage 2, hyperlipidemia, PVD, CAD with a history of prior MI, history of a cabbage times 3 in 2008. The patient is sent to the SNF for rehab, hospital discharge diagnosis, AAA repair, CKD, CAD. We have diagnoses of Z48.812 and counter for surgical aftercare following the surgery of the circulatory system, N18.2, chronic kidney disease, stage 2, mild, I73.9, peripheral vascular disease, unspecified, and Z95.1, the presence of an autocoronary bypass graft. How would you order these ICD-10 codes for reimbursement? In this example, Z48.812, the encounter for surgical aftercare following surgery of the circulatory system, is your primary diagnosis for I0020B and your UBO4 FL67. N18.2, chronic kidney disease, stage 2, could be then followed by I73.9 for peripheral vascular disease unspecified, and finally Z95.1, the presence of an autocoronary bypass graft. Let's look at another scenario. Patient admitted from hospital following an elective total right hip replacement for OA. During the hospital stay, the patient was transfused with 2 units of blood for acute blood loss anemia and continued to be anemic on iron supplements. Following the surgery, the patient was placed on Coumadin for DVT prophylaxis until such time as the patient was ambulatory. The patient was sent with orders for OT and PT to check PT INR 2 times per week and CBC in 2 weeks. Our diagnoses given to us by the hospital are M16.11, unilateral primary osteoarthritis, right hip, D62, acute post-hemorrhagic anemia, D50.9, iron deficiency anemia, unspecified, Z47.1, following joint replacement, and Z96.641, presence of right artificial hip joint. How would you order these ICD-10 codes? Here, Z47.1 aftercare following a joint replacement would be your primary diagnosis for I0020B and UBO4 FL67. Under additional diagnoses, you would list M16.11, unilateral primary osteoarthritis, right hip, Z96.641, the presence of a right artificial hip joint, D62, acute post-hemorrhagic anemia, and D50.9, iron deficiency anemia, unspecified. Now that we've discussed the importance of ICD-10 coding in relation to billing, ask yourself the following questions. How likely is it that ICD-10 codes in your facility currently are accurate and will not generate return to provider codes? Who is responsible for determining the SNF admitting diagnosis in your facility? When is the admitting diagnosis established? Is it before or after admission? How can you obtain sufficient surgery information for appropriate mapping? Have you met with your hospital providers to explain the importance of timely and accurate ICD-10 codes? Will documentation support that diagnoses are active, including diagnoses that impact your NTA or non-therapy ancillary points? It is important to have conversations with hospital referral sources to discuss. All these items can dramatically impact your reimbursement. Let's discuss section GG and function scoring a little more in depth on the MDS. From what we've just discussed, we know that 3 of the 5 PDPM components are contingent in part on the establishment of functional scores in determining a resident's case mix grouper. Occupational therapy, physical therapy, and nursing all rely on section GG. The resident's functional score is calculated from the responses recorded in section GG of the MDS. So why is section GG taking on increased significance? Under PDPM, we see the elimination of section G. Section GG is an interdisciplinary assessment to be completed by both therapy and nursing. Section GG gives a more accurate indicator of function and patient ability. It paints a better picture of our patients. And finally, section GG has been standardized by CMS across post-acute care settings. Section GG is reported in SNF, in home health, and in outpatient settings. So let's compare the differences between section GG under PDPM versus RUGS 4 section G. In section G, the higher the score meant the patient was more dependent. The opposite is true under section GG. Higher scores mean more independence. Under section G, higher dependence equaled higher payment. Under PDPM, there is no direct relationship between higher dependence and higher payment. Higher function equals higher payment under PDPM. Under RUGS 4 section G, the patient was coded for the highest level of staff support provided during a 7-day look-back period, whereas under PDPM, the patient is coded for the resident's usual performance during the first 3 days of admission. Refreshing our memories to previously presented materials, Section GG function scoring for PT and OT relies on therapy recording 10 items with a total score ranging from 0 to 24. The nursing function score will record 7 items with a total score possible anywhere ranging from 0 to 16. When calculating the final function score in Section GG, we want to make sure to score each PDPM GG item individually. We want to take an average of the 2 bed mobility item scores. We do not round the answer. We want to average the 3 item scores for transfers. Again, not rounding the answer. We want to average the 2 walking item scores. Again, don't round the answer. When completed, we sum all scores and round to the nearest whole number to achieve the final function score. Of note, nursing function scores do not include oral hygiene or walking items. These will only be reported by therapy. So let's look at an example function score calculation for Section GG. In this example, you can see that under nursing, again, oral hygiene is not reported, nor is walk with turns and walk 50 feet. The bed mobility, the transfers, and the walking are averaged but not rounded until the final calculation. At the end, each item is scored and tallied and then rounded to the next whole number. In this instance, you can see that both therapy and nursing achieved a final function score of 6. So who should help us complete and gather information on usual performance for the first 3 days on admission for Section GG? The MDS nurse, resident and family, therapy, nursing, other members of the interdisciplinary team? The answer is yes, all of us. In assessing Section GG, we want to assess performance based on direct observation, the resident self-report, and reports from qualified clinicians, care staff, or family documented in the resident's medical record during the 3-day assessment window. Documentation is critical. Residents should be allowed to perform activities as independently as possible as long as they are safe. When helper assistance is required, consider only facility staff when scoring. Activities may be completed with or without assistive devices. And finally, admission functional assessment should be completed prior to the person benefiting from treatment interventions when possible. Tips for coding Section GG accurately. 1. Be familiar with the definition for each activity listed in Section GG. These definitions can be found in the RAI manual. Code based on the resident's need for assistance to perform the activity safely. If the resident does not attempt the activity and a helper does not complete the activity for the resident during the entire assessment period, code the reason the activity was not attempted. If 2 or more helpers are required, code is 01 dependent. Ask probing questions to the care staff. Remember, it is critical our coding is accurate. A dash indicates no information. Documentation in the medical record is used to support coding. Can the levels chosen pass CMS scrutiny if reviewed? In determining usual performance, it may require input from multiple persons and resources. Success will be determined by how strong your interdisciplinary team is and how well they communicate with each other. Certain items may be assessed by only one discipline. Consider processes to evaluate assessment information and determine coding responses. Post-assessment period and a follow-up meeting are highly recommended. It is recommended you use a documentation review tool. It is recommended also that you have a clinical meeting discussion to discuss your final GG results. Documentation must be present in the medical record in order to claim on the MDS. All roads lead to Rome. For years, CMS has been pushing for a client-centered model of care. PDPM is the next step in that journey. In this example, the wheel, the hub of the wheel, represents the patient. They are the center of what we do. Each spoke of the wheel represents part of the interdisciplinary treatment team, and the outer rim of the wheel is knowledge, the communication that we have with each other to know what each other is doing in delivering care to the patient. How smooth the wheel rolls depends on how good our communication is. In conclusion, who currently is responsible for the completion of Section GG in your facility? Is GG completed by one person or multiple members of the interdisciplinary team? Under PDPM, it will be required that multiple members of the interdisciplinary team are involved in the assessment of Section GG. Are you confident that Section GG is an accurate reflection of the patient's usual performance? Does your medical record support and justify the function score you've achieved of Section GG? Do you have documentation protocols in place to ensure that support is captured? Let's continue stitching PDPM together. As we discussed earlier, one of the major differences between RUGS-4 and PDPM is the fact that RUGS-4 did not distinguish patients based on their individual characteristics. RUG grouper classification is broad. It does not account for comorbidities. It does not account for Section GG nor for BIMS. An RUC is an RUC, same payment regardless of complexity of care. Payment was solely based on meeting the criteria, in this case an RUC, of 720 minutes of therapy provided at minimum, with one discipline providing a minimum of 5 days a week and a second discipline a minimum of 3. In the example to the right, you will see two patients, patient A and patient B. One is acute neurologic, one major joint replacement. You can see that they present very differently, yet their payment of $631.42 a day is identical. When these same two patients are moved from a PPS model to a PDPM model, individual resident characteristics are taken into account. Factors in Section GG, function score, play a role. Factors in comorbidities. It also factors in the BIMS. An RUC is not an RUC. In this example, patient A, the acute neurologic, has a final payment of $616.35 a day versus the major joint replacement at $608.01. Come October 1st, we will see major changes to the MDS schedule. PDPM only has 2 assessments, an initial assessment with an ARD date of days 1 to 8. Grace days are eliminated, and a discharged MDS. Eliminated are the 14, 30, 60, 90-day assessments, and also gone are start of therapy, end of therapy, and change of therapy OMRAs. There will be an optional assessment called an IPA, or interim payment assessment. There will also be an OSA, which is an optional state assessment, which will apply to us here in Louisiana. It is important to note that OBRA assessments remain unchanged. The admission, quarterly, and significant change still apply. One of the changes set for October 1st will be the addition of I0020B. This will report the resident's primary SNF admission diagnosis using ICD10 coding. It is the reason the patient is being admitted to the skilled nursing facility. Also being added to the MDS for October 1st will be the patient's surgical history. New items include J2100 to J5000. These are new checkbox items to report major surgical procedures that occurred during the qualifying hospital stay. Further changes to the MDS will be reflected on the discharge assessment. New discharge therapy collection items will be seen. These are items O0425A1 through O0425C5. The look-back period is the entire Part A stay. These items report the total number of therapy minutes provided by each discipline and under each mode of therapy, whether it was individual, group, or concurrent. You will receive a system warning, and it will be triggered if group and concurrent minutes combined exceed 25% of the total minutes performed by each discipline. Should your facility choose to do an interim payment assessment or an IPA, there will be interim performance Section GG items. The look-back period is the 3 days leading up to and including the day of the ARD of the IPA. A new MDS item that will apply to your NTA or non-therapy ancillary for comorbidity mapping is I-1300, ulcerative colitis, or Crohn's disease, or inflammatory bowel disease. In considering PDPM preparedness for October 1st, be honest with the following questions. How accurate is your MDS coding today? Are you confident that you'll be able to maximize reimbursement under PDPM? What is your relationship like with your hospitals or your admitting facilities? Do you get your paperwork timely? Is it accurate? Is it detailed? Under PPS, currently 20 items need to be accurate some of the time in order to capture a RUG category. Under PDPM, 188 items need to be accurate all of the time in order to establish a case mix group. What is your confidence level that your interdisciplinary team will be able to consistently capture all 188 items? Do you have a training plan for the new MDS changes and items that will drive payment rates? And finally, does your staff understand why and what they are documenting and what reviewers will look for if and when you are audited? The interim payment assessment, or IPA. Sometimes during a Part A stay, a resident's condition changes and the use of an IPA is appropriate. An IPA revises payment during the Part A stay based on condition or conditions that change, warranting a change in the clinical category. The use of an IPA is a 100% optional assessment. Providers will set their own criteria to determine if an IPA will be performed, and the payment changes will take effect on the ARD date established. This sounds funny to say, but the MDS IPA will have its own IPA item set. It will contain payment and demographic items necessary to attain a billing code under PDPM. Optional, and will be completed when providers determine that the patient has undergone a clinical change that would require a new MDS assessment. The ARD date is determined by the interdisciplinary team based on the clinical change. The IPA does not affect the variable per diem, and the IPA cannot be combined with any other assessment. When determining whether or not an IPA should be performed, it is recommended that your facility develop a policy and educate the entire interdisciplinary team as to your criteria for when an IPA will be used. Perform self-audits to ensure that the IPA assessments are being completed in line with your established policy. Take into account significant changes in clinical status and care needs. Has there been a change in cognitive impairment? Mechanically altered diet? Is there a new swallowing disorder? Does the patient need respiratory therapy? Are there new wounds, IV medications, or changes in functional status? Another exciting change to PDPM will be the introduction of the interrupted stay policy. This is getting an overwhelming 2 thumbs up from both MDS nurses and therapists alike. The interrupted stay policy will take effect and is applied when a patient discharges from the skilled nursing facility but is out less than 3 midnights. If this occurs, no new MDS is required. The interrupted stay continues and the patient resumes the prior case mix components and payment. The variable per diem adjustments for non-therapy ancillary PT and OT do not reset. If the patient returns after 3 midnights or 3 days, a new MDS will be completed and everything starts over. If the resident admits to a different SNF, a new MDS is always completed and everything starts over. The interruption window is a 3-day period starting with the calendar day of discharge and including the 2 calendar days immediately following, ending at midnight. OBRA assessments will still be required. The interrupted stay policy as written will mitigate potential incentive for providers to discharge and readmit Part A patients for the purpose of resetting their variable per diem schedule. Another positive to the interrupted stay policy is it's designed to ease administrative burden caused by completing assessments for each readmission. This is in line with CMS's paperwork reduction initiative. It applies not only in instances where the resident physically leaves the facility, but also in cases where the resident remains in the facility but is discharged from Medicare Part A and their Medicare Part A stay. The source of readmission is not relevant. The beneficiary may be readmitted to the SNF from the community, from an intervening hospital stay, or from a different kind of facility, and the interrupted stay policy would operate in the same manner. MDS discharge assessment in therapy. As mentioned earlier, the discharge MDS assessment will contain a new item set that will track therapy start and end dates. It will also look to track minutes of therapy provided by discipline and by type and mode of therapy, comparing individual to group to concurrent. CMS has been very clear that they are going to monitor significant decreases in the amount of therapy provided. They urge providers to remember that PDPM is a payment change, not a care change. They will also be monitoring group and/or concurrent therapy exceeding the 25% allowable. The discharge assessment will serve to provide data for future rulemaking and potential payment changes. This data that is provided can be linked to medical review. Let's discuss modes of therapy. Under PPS, group and concurrent therapy are allowed. However, they are restrictive due to the documentation requirements and the parameters that have been used to define both group and concurrent. Under PDPM, a total of 25% of the overall provided minutes by discipline may be performed as a group or in concurrent therapy. Penalties may result if you exceed the 25% allowable. Non-fatal errors will be seen in your QIES ASAP system, notifying you that you've exceeded the 25%. And it could flag providers that consistently exceed the 25% by way of medical review. Please always remember that CMS has a look back of 5 years and can issue a denial of service. Just because you were paid doesn't mean you will stay paid. Per the 2020 SNF interim rule, CMS is proposing redefining the definition of group as being a Part A group therapy performed by a qualified therapist or therapy assistant treating 2 to 6 patients at the same time who are performing the same or similar activities. In conjunction with group therapy, these two groups may constitute up to 25% of the resident's total therapy provided services per discipline. Group therapy advantages under PDPM. It is a major victory to see the removal of the restriction that group had to consist of 4 residents. All group therapy minutes are counted towards the resident's total minutes under PDPM versus group therapy minutes being divided by 4 under PPS. Group therapy under PDPM will offer therapists more flexibility. In smaller facilities, you may not have 4 patients who would benefit from a group activity. The proposed rule would allow for a smaller or larger group size as defined by patient need. However, before we get too excited doing the happy dance, let's remember that under Chapter 8 of MedPub 100-02, the documentation requirements for group remain in effect. That being said, the 2020 final rule, you may see changes to that policy, but at this time, CMS still requires that therapists must be able to support and justify the need for the chosen group size. They also must be able to support why group is the most appropriate mode of therapy. And finally, the resident's plan of care should reflect explicit justification for the use of group. Cited directly from the 2020 SNF proposed rule, 1, therapists should be able to demonstrate using adequate documentation the clinical judgment they use to determine whether groups of different sizes would be clinically beneficial to their patients. 2, CMS continues to believe that individual therapy is the preferred mode of therapy provision and the standard of care in therapy services provided to skilled nursing facility residents. Group therapy isn't always appropriate and is primarily effective as a supplement to individual therapy. As a result, therapists also will need to document their use of group in order to demonstrate why it is the most appropriate mode of therapy for the patient who is receiving it, says the agency. The following excerpt delves a little further into the group therapy documentation requirements. SNFs should include in the patient's plan of care an explicit justification for use of group, rather than individual or concurrent therapy. This description should include, but not be limited to, the specific benefits to that particular patient of including the documented type and amount of group therapy. That is, how the prescribed type and amount of group therapy will meet the patient's needs and assist the patient in reaching documented goals. Compliance risks under PDPM. First, documentation that does not support the skilled services being provided. A noted or significant change in the therapy provision of how therapy is delivered. Major changes to the volume of therapy services being provided. No weekend treatment. 25% group or concurrent, or exceeding 25% group or concurrent when none has been provided previously. Insufficient support for length of stay. Overuse of group and concurrent, non-individual modes of therapy that are not supported with clinical indication. Documentation supporting use. Not monitoring the 25% group and concurrent. Unsupported section GG function scores, and overprescribing modified diets or unsupported swallowing disorders. These are all areas that CMS will be monitoring and looking for major changes in how care is being delivered compared to your current patterns. Facility evaluation. How much group and/or concurrent therapy is currently happening in your facility? CMS reports that over 98% of therapy is being provided currently on an individual basis. How feasible is group and/or concurrent with your patient population? Have current restrictions prevented the use of group in the past? Will there be opportunities under PDPM? How will you monitor group and/or concurrent use under PDPM to ensure that the 25% limits are not exceeded? Remember, these figures are not calculated until discharge. Can you maintain or exceed outcomes with group and concurrent therapy? CMS is firm that group and/or concurrent therapy cannot be provided for facilities or for therapist convenience. The resident must benefit from these modes of therapy in order to use, and your support must be explicit. An area that seems to be weighing very heavily on facilities' minds is timely data collection. 100% of the resident's payment will be determined on day 5 or the initial MDS assessment. You have a total of 8 days to, quote unquote, get it right. The MDS must be completed on days 1 to 8 of the Part A stay. MDS information must be supported by documentation in the patient's clinical record. And the collection of data should begin ahead of the SNF admission. So how do we work smarter, not harder? First and foremost, lean on your interdisciplinary team. Under PDPM, the one-man show approach is a recipe for disaster. We want to make sure that we consolidate efforts, develop a pre-admission screening so that we know what we're getting into with each admit. We want to see department-specific evaluations, and it's going to be very important to know the patient's prior level of function. With that, we are going to want to establish a baseline care plan. We want to have an idea of what kinds and types of care the patient will need. We're going to want to reconcile medications so that we know our costs, and we want to see restorative programs take effect at the beginning of care, not at the end of care, where appropriate. Furthering our discussion of evaluating your facility and your current situation, how timely do you receive hospital paperwork? Are the hospital diagnoses included? Are they specific? And are they accurate? If diagnoses are added early in the stay, how will this be communicated to the MDS, to therapy, to nursing? How do you currently handle documentation discrepancies between therapy and nursing? Who is involved in care planning? Is your therapy team involved? Do you have the appropriate amount of staff to care for the acuity of patients that you're going to admit? If weaknesses exist above, how do you plan to improve those? We're in the home stretch. Let's quickly discuss the skilled level of care criteria. Under PDPM, it will remain the same as it is under PPS. A resident being admitted for Part A will require daily skilled service. They must have a 3-day qualifying hospital stay and have supportive documentation justifying why care is essential to the patient's well-being. As with PPS, presumption of coverage will continue under PDPM. PDPM classes designated under presumption of coverage include the extensive services, special care high and low, and clinically complex in the nursing component. For physical therapy and occupational therapy, categories TA, TB, TC, TD, TE, TF, TG, TJ, TK, TN, and TO will be covered. For speech, categories include SC, SE, SF, SH, SI, SJ, SK, SL. And under the non-therapy ancillary components, the uppermost 12 plus comorbidity groups will be covered under presumption of coverage. Presumption of coverage is tied to the initial MDS assessment that is completed at the outset of the SNF stay. This is consistent with CMS policy. Admissions that occur on or after October 1st, 2019, a 5-day assessment may trigger a presumption of coverage only when the SNF admission directly follows discharge from a prior hospital stay. PDPM default billing is also being termed as a sleep at the wheel. It is being termed this because under PPS, no longer will you see AAA, but under PDPM, it will be 5 Zs. Equivalent to billing physical therapy at a TP level at 1.08, an OT level at 1.09, speech in an SA category at 0.68, nursing in a PA1 category at 0.66, and your non-therapy ancillary at an NF at 0.72. So what can we expect come October 1st? There will be no blended rates, grace periods, or transition period. On October 1st, 2019, all patients transition to PDPM regardless of their SNF admission date. For patients admitted in late September with less than 5 days, you will not get special consideration. The RUG is the RUG, based on the data of date of admission to September 30th, not the RUG you were trying to establish. An interim payment assessment will be required on all existing Part A patients, and the established ARD date cannot be later than 10/7/2019. This is the only time an IPA will not be optional. October 1st is considered day 1 of the variable per diem schedule regardless of the SNF admission date. The transitional IPAs that have an ARD date submitted after 10/7/2019 will be considered late and penalties will apply. Effects on Louisiana Medicaid. CMS will continue to report RUG 3 and RUG 4 HIPS codes based on state requirements in item Z0200. That said, as of October 1st, 2019, all scheduled PPS assessments, except for the 5-day, and all current unscheduled PPS assessments will be retired. CMS has created an optional state assessment, or an OSA, so Medicaid payments are not adversely impacted when PPS is implemented. States have the ability to determine policy associated with this assessment to meet the Medicaid payment needs. Section S items, the requirements for completing the OSA, would be set by each individual state. It is important to note that the OSA, or optional state assessment, will not contain coding instructions in the MDS 3.0 RAI manual. Completion of the OSA is at the discretion of each state. The RAI will not provide direction on the coding schedule of the OSA. No additional data elements such as Section S items may be added to the OSA. The OSA cannot be combined with any federally required assessments, and CMS will continue to report the RUG HIPS codes as requested by the state on the 5-day PPS, OBRA comprehensive, and the OBRA quarterly assessment types. If a state requires a RUG calculation more frequently, the state may require its providers to submit the OSA at time points determined by the state. I want to thank you all for taking the time to learn more about PDPM and navigating our Medicare future. My name is Lance Hill. I'm an Executive Vice President with the Therapy Center. My contact information is attached to this slide. If you have any questions, please don't hesitate to reach out. Have a wonderful day.